because it is a public meeting. The recording will be posted on the board's webpage shortly after the meeting. TVW may also be streaming this and archiving it for additional viewing opportunities. For everyone's reference, today's agenda can be found under the first tab in the materials. And as a reminder, if you are not a member of the board, please turn off your camera now. Sue Birch, Chair of the Healthcare Cost Transparency Board, will now call the meeting to order.
Great. Thank you so much, Mandy. Welcome, board members, and to my right, Ingrid, welcome. She's here in person. I'm calling this meeting to order it is now 2:06. So we are going to begin with our meeting. Just for members of the public, this is the October 18th meeting of the Healthcare Cost Transparency Board. And again, welcome. I love having a board member in person.
It was only a block away. I didn't have a big excuse.
Ingrid, thank you for walking over. And all board members know you're welcome to come down or up to Olympia or around. It's always great to see people in person, but it is also awesome to be able to continue to have these meetings hybrid for those that want to listen in. So I want to, well, first, Ingrid is our new member, and for those of you that don't know, Ingrid Ulrey is the director over at Health Benefits Exchange, and she is a key partner of ours in the what we call the Health and Human Services subcabinet. And Ingrid hails to us with a long history in health and human services. Before this, she was with CMS as the Region 10 director, HHS director, and prior to that was with King County, has an extensive history in aging, and it is just so great to welcome you. And Leah will be missed, but I bet she's listening in. So now we'll have two sets of brilliant ears listening in with us. Anything you want to say, Ingrid?
Oh, no, just thank you. I'm really excited to be a member of this board, and this is so critically important for our state and for what we do lobby to secure affordable access to qualified health plans. And I just want to say, I just want to acknowledge Leah Hull Marshall as and her incredible leadership on these issues. I will be leaning in heavily to Leah as I participate. Thank you.
Great. Welcome. It's going to be an ongoing fun journey together. So I also wanted to mention that we are really pleased. Connecticut and Washington collaborated. Thank you to Mandy on an article that is debuting in Governing Magazine. We'll get that out to everybody, but it is on your work. It's on the work that both states have done to better embrace cost containment and the efforts, and I think it really does a nice job. So we'll get that out to you all. There's another article that came to our attention via the House Health Committee, and it is in The Economist, and we'll get this out to you as well. The title is really pithy and I think good for all of us to read. And the title is "Who Profits Most from America's Baffling Healthcare System?" And then it says in smaller print, hint, it isn't big pharma. So I will make sure that this comes out to all of you as well. You know, a little spoiler alert, it talks about the continuum and all kind of the third-party intermediaries. It talks about their growth. And again, it's something that our board has said we'll get to, you know, all parts of the continuum, the healthcare continuum. But this article really does a nice job. If you're an Economist subscriber, you probably already read it, but the board will be intrigued by that information. All right, let's move on. I want to provide a brief overview of today's agenda. We're gonna, in a minute, begin with that roll call. And when we call on you, though, as before, we're gonna do something kind of fun. We're gonna ask you to talk about what your favorite part of fall is. After the roll call, we will introduce the June meeting summary to approve. Then we're going to hear public comments. After the public comments, Dr. Zerzan Tull from, I always get Judy's last name mixed up, Zerzan Tull, who's the chair of our Primary Care Advisory Committee, is going to provide the committee's recommendations on non-claims-based measurements for primary care. Then we're going to hear about statewide affordability activities from the Health Benefit Exchange, HCA, and the Office of the Insurance Commissioner. After that, Vishal Chowdhury will provide an update on the benchmark. and analytics status. And then to close, we'll engage with the Analytics Support Initiative and provide direction for the upcoming work. I really, really, really encourage you all to ask questions, give feedback. It just makes for a richer conversation and process throughout. So it helps us just with the discussion and recommendations. So I look forward to this meeting. All right, so thank you in advance for your all the insight you're going to provide. And don't forget, you're going to share what your favorite part of fall is. And my favorite part of fall is anybody that knows me will not be surprised by this since I'm a foodie. I love making kind of soups and stews, and that the aroma of that crock pot when you walk in the door and there's that cauliflower, carrot, chowder ready for you. So anyways, that's my favorite part of the fall. So I'm going to move into that roll call. Jane Beyer, what's your favorite part of fall?
Good afternoon. My favorite part of fall is probably taking the last hikes of the year up in the high country when it's still open and seeing all of the colors, the lovely colors.
And I have been on some of those hikes with you, Jane, and I know how much you love to hike, and I'm hoping we can get one of those in still. Eileen Cody. I think Eileen might be traveling. Eileen is, okay, we'll move on. Staff, let me know if she jumps on, but I'm pretty sure she's not calling in. Okay, Lois Cook.
I have a beautiful Japanese maple outside my office window, and I love seeing the bright red leaves.
Oh, I can see that, and I have not been outside today, so thank you for that image. Bianca Frogner, are you with us?
I am with you, and I'm apologies. I'm somewhat traveling, and so I'm in a car, so I'm going to stay off video for most of, at least for the next hour or so. But yeah, I'm here, and yeah, I feel like I agree with the first statement about the change in the fall air and seeing the beautiful leaves. And I grew up in California in an area that didn't have a lot of changing color of the leaves, and I subsequently lived on the East Coast and now here in Washington State. And it's so fun to see the change in color of the leaves and just the beauty that that brings. Not so sure I love the raking of the leaves part though, but otherwise it's beautiful.
Thank you for that. Jody Joyce. All right, staff, let me know when Jody jumps on. Mark Siegel. Don't think Mark is with us yet. Margaret Stanley.
Hi there. Well, I really like the same thing that I like in the summer, which is going for walks in the beautiful weather.
Lovely. I'll get on a walk with you, Margaret. All right, Ingrid.
Well, where are those the cameras that
Yes,
way?
yes.
Okay, I just looking where to look at. The owl, I'm confusing the owl. Okay, so I'm gonna call out Halloween.
Oh, that's good.
And it was particularly fun when I had little boys, but they are now grown men. But I have found at the exchange, Halloween is a big deal, and they've actually rebranded it Wabaween. I'm excited.
Oh, that is great. Wabaween. Kim Wallace, can you top that?
Oh, I don't think so, but hi, everyone. I'm just going to say that I really appreciate the sort of crisper, cooler air overnight.
Lovely. Oh, that is delightful. Carol Wilms. Oh, Carol said she had a conflict and she's not going to be attending today. We'll find out if she likes pumpkin spice lattes. Edwin Wong, what about you?
Yeah, I think I'll stick with that pumpkin theme and maybe new this year. I'm finding I'm enjoying a lot of the pumpkin themed foods, whether it be pumpkin kind of beer, pumpkin brews, pumpkin desserts, pumpkin breads. Yeah, so haven't been traditionally a big fan of pumpkin, but find I'm really enjoying it this year.
Hey, Edwin, I'm going to send you a pumpkin spice chili recipe, a pumpkin chili recipe that I have that is amazing.
Oh, that's fantastic. I would follow up
Send it
with you
out
on
to the
that.
whole board. It's really good.
Fantastic.
You never know it was pumpkin. All right, thank you. I think we got everybody. We're gonna move into our agenda now. The second item is the approval of the meeting summary. And if you'll turn to tab 2 in the board book, and the minutes are up on the screen. I want to again make note that the recording of the last meeting is posted on our webpage for reference or for review. And we're going to use a consensus process for the vote on the approval of the meeting summaries. Is there any discussion of the June meeting summary or any proposed changes? I'm not seeing any or hearing of any. So is there a motion to approve the minutes?
So move.
Thank you. I think that was Margaret. Is there a second?
I'll second.
Thank you, Lois. All in favor, say aye.
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 Any opposed? Great. So the motion is approved. All right. In your public comments packet, you're going to find that a member of the advisory committee of the providers and carriers and a member of the advisory committee on data issues requested that their committees consider bringing a motion to the board to respond with answers to a series of questions from those members representing the Washington State Hospital Association and the Washington State Medical Association on these committees. And you will, if you look at tab 3, you'll see these, the related information. And at each meeting, the HCA staff offered to provide responses to those questions, and the members in attendance at those committees found and voted that was sufficient rather than requesting the board to respond. So while this is not an agenda item today, I wanted to identify this for the board members to identify the requests and the efforts that have been undertaken to be responsive. And under tab 3, you're going to find the responses to those questions, including a series of supplemental resources developed to provide additional information and references. And you'll also find a copy of the motion. So any questions about that? Questions or comments? And I want to, on behalf of the board, thank you guys. I think this was great how you collated kind of the topics and then the response and just really pulled things together. It's really well organized, and I know it took a lot of time and attention, but really well done. All right. All right, we're going to move into public comment. I remind the board, we put this earlier in the meeting process. Written public comments received since our last meeting can be found under that 3rd tab in the board materials. And we allow individuals to sign up to provide public comments before the meeting. And we will start with those that have signed up to provide comments. If you are listening in and you have not signed up and would like to provide a public comment, please signal by raising your hand. And then Mandy can call on you after we hear from individuals who have signed up. The process will be when we call upon you, state your name and affiliation, if any, before speaking. And please accept the invitation to become a panelist in order to provide public comments, okay? I think we have some participants raising hands, which is great. Please don't raise your hand more than once, and it just helps us kind of ensure that everyone has a chance to speak. And you're also welcome to provide comments in writing via email at any time. So Mandy, would you please start with the names of individuals in the queue who have signed up to provide comments?
Katerina Lamarche.
Okay. So was it Katerina?
Katerina Lamarche.
Yes. So Katerina Lamarche, if you would open up your mic and provide your comments.
Sure, thank you. Katerina Lamarche, I'm a policy director at the Washington State Hospital Association. I'm actually providing comment for Jonathan Bennett, who was Bush's representative on the Data Advisory Committee because he couldn't be here today. So as you referenced just now, Jonathan submitted a comment letter that's included in the meeting materials, which explains his recent attempts to work with the board and committees and staff to help strengthen the benchmarking process. The motion that he introduced at the last data advisory committee is detailed in that letter and was passed with an amendment to have the questions first be considered by the data advisory committee. He said that he is really looking forward to having those discussions and developing recommendations for the board. I'd like to say, we do really appreciate the inclusion of information that accompanies the letter in the meeting materials, but I would like to provide just a little bit of clarification. We know the benchmark calculations have been discussed with the board, and we understand the methodology, but I think the motion asks questions that we don't think have been addressed to date. The question about risk adjustment, is whether providers will be able to see the adjustment and, understand how their practices are scored on that measure. It asks if providers will have an opportunity to vet the data used to determine their benchmark performance. Excuse me, and whether they'll be able to identify which providers are assigned to them and which patients are assigned to those providers. It also asks what information and analysis will be given to providers on their performance and how that compares to their peers, how it's going to be presented, and how to make it really as useful as possible so that providers can change and improve their performance. We really feel strongly that providers need to know that the information on their cost increases is accurate, based on reliable data, and that the information is also actionable. We do know that the upcoming benchmark analysis just measures the baseline year and not providers' performance, but we really think that the questions should be addressed now, just to ensure that there is enough time for thoughtful consideration. So thank you again for the opportunity to comment, and if you have any questions, please let me know.
Thank you for those comments, Katerina.
We have Tom Hightower.
Tom, if you'll open up your mic, if you want to come on camera and present your comments to the board, if you'll state your name and affiliation.
Tom Hightower, President of the Board of Commissioners at Olympic Medical Center. Can you hear me?
Yes, we can.
Okay. Since Olympic Medical Center is a public hospital district, my position as commissioner is elected by the residents of the district. Olympic Medical Center is located in North Olympic Peninsula. We have one hospital and a dozen clinics that serve a population of roughly 70,000 people. Much of the population we serve are retirees. We are a safety net hospital and designated as a rural sole community hospital and a rural referral center. We are also one of the largest employers in the region with more than 1,600 individuals working for us. Like every other organization, the cost of goods and services necessary to provide healthcare patients have increased dramatically with inflation over the past couple of years. Statewide, hospitals lost $750 million from operations in the first 6 months of 2023. In addition to general increases in expense, we had unforeseen expenses in 2022 related to the necessary costs of the pandemic. Another factor is the increasing in labor costs and contracted labor throughout the pandemic. Unfortunately, going into 2023, the trend of increasing labor costs continue, as does our reliance on contract labor. From a revenue perspective, our commercial payer mix has also shrunk from almost 18% to less than 15%. As such, revenues have come in far below budget in 2023 so far. We are operating at a loss at this time. The underlying purpose of limiting healthcare cost growth is to ensure access to healthcare services. If the benchmarking process penalizes large providers for paying for labor and supply and equipment necessary to sustain healthcare services in our communities, the benchmarking process will undermine the goal of providing access to care. The benchmark should reflect inflation, wage growth, and operating losses, so there is a more accurate understanding of provider performance in the broader economy. Unless there are unexplained and unjustifiable increases after considering all factors, hospitals and other large provider organizations should not be named and shamed or worse. This will only put our access healthcare services at risk in communities like mine. Recognizing the board is still early on in this process, I would ask that you proceed in a transparent and measured manner as you continue your work. Thank you for your time today.
Thank you, Tom. Mandy, who's next?
Jeb Shepherd.
Director Birch, members of the board, my name is Jeb Shepherd, Director of Policy at the Washington State Medical Association. I appreciate the opportunity to provide public comment this afternoon. Would like to thank the Healthcare Authority staff, especially Mandy and Ross and their team for putting together information that WSMA and WSHA requested in various motions over the summertime around attribution methodology, risk adjustment, tools for providers to understand and improve performance, and notification to large providers that will be publicly reported against the benchmark. We understand that per the motion, this information will go back to the Data Advisory Committee for review. And we hope that the board will take into consideration recommendations that the Data Committee makes in response to this information, and that staff continue to work with us on follow-up and additional questions as we help providers understand and improve their performance under the benchmark. The reason why we're so focused on these elements right now is, even though we've been assured that large providers will not be publicly reported on until 2025, is if we understand the reporting schedule correctly, the performance period for those years are right now. That's 2022 and 2023. And entities that will be publicly reported on still do not know that that will occur. So there will be no opportunity to improve performance before that public reporting. We urge the board and staff to work with the data and provider advisory committees to help providers understand their relationship to the benchmark and the data needed to improve their performance. 2024 will be yet another difficult year, as noted by the previous commenter. The provider community has healthcare costs are expected to increase significantly in the next year due to input prices, things like medical groups do not have control over, such as increased price of goods, unnecessary administrative burden, prescription drug costs, and labor. And so we urge the board to work with us to set up physicians, other providers, and patients for success under this and future iterations of this board. Thank you.
Thank you, Jeb. We appreciate all the comments we're getting. Mandy, is there anybody else?
Anybody else?
All right, so this is the last call for public comment. If you have not weighed in, we're going to give you about 15 more seconds to signal to us or open up that mic, but I don't believe we have anybody. So we are now going to close public comment and continue back to our meetings. I will just say for the board members, like we have pledged all along, we're on a journey together and we're ingesting data, we're ingesting feedback, we're working with our advisory committees, and as the legislature has charged us, we are on this exploratory path. So those comments will be rolled into kind of all of our ongoing efforts and discussion and dialogue. So we always appreciate public comment. All right. We are going to move on to tab 4. The presentation before us is now on the primary care committee recommendations, and our very own Chief Medical Officer, Dr. Judy Zerzanthal, is on with us. Judy.
Thank you, everybody. Good afternoon, and I'm just going to give you a quick update and then ask for a vote as the primary care data committee continues to work. We are getting closer. I think this month we're going to review some data from our preliminary spend code decision. But before you today, I'm going to talk about how we're going to collect the non-claims based information and ask for your approval. So next slide. Which actually, I guess, is everything that I just told you, but the box is around what we have to do. You have approved the definition of primary care. And today we're gonna talk about data collection for non-claims based spending. We are very close to finalizing the methodology for the claims-based spending, and then the additional pieces of barriers and progress will come to you at a later meeting next year. Next. So I wanted to take a moment to talk about how data collection happens right now. So from the all-payer claims database, we get detailed data submitted by a subset of payers to the APCD. The APC data can be queried by HCA, and this is how we have traditionally measured our primary care spend using the OFM definition. Of note, this does not include the ERISA plans unless they opt in, and it does not include non-claims based expenditure. The second way that we get data is the HCA aggregate data call. And this involves getting data from all payers directly to HCA. It does include ERISA plans data, and it includes non-claims based expenditures. And as we have finished our first, and I think you heard recently, we're continuing to sort of update those specifications to get good data to report solid numbers. Next slide. So the existing aggregate data call could be modified to incorporate the board approved primary care definition and solve for the missing elements in the APCD. However, there are a number of challenges. The first of that is that multiple entities would calculate the primary care expenditures based on the state provided specifications. And as we have learned through this process, and HCA has been collecting primary care spend from the MCOs and from our PEB and SEB plans. And this is rife with opportunity for inconsistent application of the specifications. There are a number of errors, and that self-reported aggregate data in some ways reduces the accountability and the transparency, because you can't dive into it if you are interested in that. This process is also administratively burdensome, and it's partially duplicative with the APCD reporting by plans. Next slide. So we are proposing a hybrid solution for data collection, that our claims-based expenditures come from the APCD. This matches what we have been doing and really takes away those challenges that we have, so that there's standardized reporting and interpretation, there's increased transparency, and it leverages the existing infrastructure. We do have one ERISA plan that is working on being included in the APCD, so this may provide an opportunity to further strengthen that resource. However, that does not have the non-claims based expenditures, and so our solution for the APCD data gaps is to ask with the data call for plans to report to HCA their non-claims based information. And this can be customized under a value-based purchasing framework like the Healthcare Payment Learning and Action Network, or some other categorical framework. And I think that is my last slide. And so I don't know, I think Sue, maybe you lead this to see if you guys have questions about this approach, and if you want to vote to approve it.
Thank you, Judy. Are there questions from the board?
Sue, not a, whoops.
Go ahead, Jane. I think
So
your hand is up.
Yeah, not a question, but just to note that actually, my understanding is the APCD does include state employee and school employee claims, PEB and SEB, and the Uniform Medical Plan is about 300,000 lives. So there is some self-funded health plan data in the APCD.
Yes, that is right. And it is optional to do. And as I said, there's, I think there's going to be another plan coming in, but it also has the Medicaid and Medicare lives. So it is a reasonably robust data set. It's just not 100%.
Thank you.
Okay.
I can't see whose hand is up. Go ahead, Kim.
Yes, it's a whole bunch of us here. I just wanted to make the comment that an assumption I have is that the pursuit of reporting of non-claims-based expenditures would, of course, be accompanied by some really clear guidance and definition regarding what constitutes non-claims-based expenditures, so that what you were talking about a little bit a couple minutes ago about the, sort of the unhelpful variation, in the data would not occur. Is that so? Are we pretty clear that we can communicate effectively and get compliance with the submission of non-claims based expenditures?
I think so. Again, it won't be 100%. We have been collecting at HCA non-claims-based expenditures from PEB and SEB and Medicaid, and it has been variable, but every year we've sort of learned from that and refined. And so I think that we're getting better at that. And it is a smaller set of things to ask the plans to report in some ways. It's a little clearer than a really long code dump, especially because on the claims-based expenditures, as you might recall, we sort of have the intersection of the provider type that's providing it, the service, and the location. And that is a much more complicated way to do it. And we've had much more, I think, variation in the claims-based spend than I would guess by giving them the information. I think that's going to be easier on the non-claims-based side, and we are continuing to learn. So
okay, yep, makes sense. Thank you.
Bianca?
Hi, thank you for this explanation, Judy. I imagine there must be a bit of a Venn diagram between those who are providing data through the APCD and then those who are going to be providing data through the non-claims space. So I'm curious how you imagine some of this reporting will come together. Will we only basically be looking at those who provide data through both of these elements? So only, how will we deal with, I guess, the gap between those who are in the APCD but aren't able to provide the non-claims based data? And maybe it's probably more likely, I'm guessing, that some people are going to provide the non-claims based data. They're not going to have the claims data.
Yeah, that's a great question. So I think we'll have to sort of caveat of what it looks like. We've in the past sort of divided, had sort of an overall number and a Medicaid and a Medicare and a commercial number for claims-based spend. And so I suspect that that will be similar. The question I thought you were going to ask is that this non-claims-based expenditure we would put in with the overall data call, so it'll come out at the same time as the annual data call. So as other things are being added up, then we can sort that out, because I think it's important that they're sort of over the same time period and coming out at the same time to avoid confusion.
Maybe can I just ask a follow-up to that then? So in the data call, does it seem fairly complete in terms of how many folks and entities are responding to that data call? I'm sorry if I missed kind of what that response rate seems to be like these days.
Oh, so I was talking about the data call for you guys for the overall cost board.
I see.
Yeah.
Okay. Thank you. Sorry.
That's okay. Yeah.
Margaret was next.
Yeah. On the HCA aggregate data call, it said it would include ERISA plans data. I'm wondering, would that be voluntary on their part? Because I don't think you could require ERISA plans to submit.
Yes, it is voluntary.
Thank you.
And Edwin, I think you're next in the queue.
Thank you. Thanks for laying this out so clearly, Judy. Just a question, maybe a follow-up a little bit to Bianca's question, and kind of a two-parter. I guess the first is maybe you have some examples of some of the non-claims-based expenditures that are in the second data set that are not in the first. And then the second part of that question is, are you able to, I guess, partition or to clearly kind of separate the claims-based and the non-claims-based parts such that the two are mutually exclusive? And the rationale for that question is I just want to be sure that we're not double counting anything.
Yeah, that's a great question, Edwin. So some examples of non-claims-based expenditures are like quality payments that get made, or sometimes plans provide specific practices, money for care coordinators or help with an EHR or something like that at their request. So those kinds of things might be in non-claims-based expenditures. Also in non-claims-based expenditures could be sort of capitated payments like primary care per member per month, which some of our MCOs do now, and I know some commercial plans do now for certain practices. And so I do think it's sort of important to get both of those pieces together, because those non-claims-based per member per month is the amount of money that we want to get for the numerator and denominator, rather than the shadow claims that maybe are happening and might be collected, but don't have a payment associated with them. And so I think that how we're envisioning it is that we'll be able to keep those things separate, and the payments aren't duplicative.
Thank you.
There are other questions? If not, I want to welcome Lois's cool cat with the white tip tail to the meeting. We love animals, especially Judy. She loves animals big time. So no,
That was Rusty.
Are there other questions on this topic? All right. If not, thank you, Judy, for your work with the Primary Care Committee and for continuing to advance this issue. I know from Mark McClellan at the Margolis Center in North Carolina, I just got off the phone with him, and he says you continue to be a champion for multi-payer and primary care work. So thank you for all of this. All right. Oh, I'm
so
sorry.
I think we need a vote. Yes, because that'll allow us to keep this moving forward.
Absolutely. Thank you, Mandy.
No problem.
So we, on these recommendations, we're going to go ahead. Is there a motion to adopt these recommendations on data collection and reporting for claims and non-claims based measurement?
So moved.
Thank you, Jane. Is there a second?
I'll second.
Any further discussion? Okay, all those in favor say aye.
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 Are there any opposed? All right, the motion is approved. There you go, Judy. Thank you again. All right, next we're going to move on to other statewide affordability efforts. So under tab 5, we will have our very own Michelle Needham from HCA, Laura Kate Zeichin from the Health Benefits Exchange, and Jane Beyer from the Office of the Insurance Commissioner, who are going to provide us with an overview of other statewide affordability efforts. So I think Michelle is starting us off. Go ahead, Michelle.
Great, thank you, Sue. Let me do a sound check to see how the sound is online. Okay, could you give me a signal if you can hear me? Lois, thank you. Love it. Just the microphone in the room is a little challenging sometimes. Again, Michelle Needham, I'm the Chief Policy Officer for Healthcare Authority, and I'm just here today to provide a brief introduction to some of the other activities underway across the state. In addition to all the studies we have with the board and the data streams that Michelle and Joe are going to talk about shortly, we have some other activities and studies that we participate in with other agencies such as the Health Benefit Exchange and the Office of Insurance Commissioner. And we wanted to highlight a couple of cost transparency efforts in particular. So this is a particular slide just summarizing some of our sample transparency efforts. So we, as you probably remember, have a prescription price transparency reporting effort that is annual. The Department of Health has some hospital financial reports, and they get a lot of different financial information that we will be using. As mentioned previously, we host the all-payer claims database here that provides a lot of information on spending for the bulk of Washington Healthcare. Obviously, we called out the Healthcare Cost Transparency Board as a key effort in highlighting some different costs. And our newly standing up Prescription Drug Affordability Board, it meets for the first time on Friday, will begin to dive into the particular drivers with prescription drugs. So we will not spend as much time in this board on some of those efforts, but we will be linking that with your work. So you will hear more about that. And this is a slide just to give you a snapshot of some of the other studies that we have. In addition to the cost board studies, we have a number of things related to those prescription drug reporting requirements, some studies that the exchange has underway related to our Cascade Care public option that we help purchase with the exchange, and the impact on the hospitals and consumers, as well as their 1332 or their federal waiver that helps fund some expansion for the immigrant program. So those reports are all coming. We're working with them on those. The Office of Insurance Commissioner has a report that Jane will be talking about just shortly that we are helping with as well on different targeted affordability efforts around our healthcare marketplace. She has some additional ones, so I won't go into what Jane is going to provide a brief overview on. We have different reporting on our managed care rates and our aggregate experience here within the board that you should be hearing more about just shortly from Michelle and in our next December meeting. See, I'm trying to hit some highlights. In addition, we have the Universal Healthcare Commission that we host in the Healthcare Authority, and there are some related efforts that unite with this work on affordability and expansion efforts. And that report is just being submitted this week, I believe. So a number of different things I just wanted you to be aware of, and in case we haven't captured them in your assignments, specifically want you to know that there are other discussions on affordability. And we will, of course, be bringing some additional work in the new year in 2024 on more of those policy options that would dive into additional cost control efforts. I think that transitions to our Kate. Correct. Happy to answer questions about the studies, but I'll be here if you want to ask after all the presentations.
Hey, Laura Kate.
Hi, everyone. Good afternoon. Nice to see you. I'm Laura Kate Zeichkin. I'm a senior policy advisor with the exchange, and my pronouns are she, her. Thanks to the board for inviting us to provide some information within the snapshot about the individual market. We can go to the next slide. I think folks are very aware. You have representation here in Ingrid on the board of who the exchange is. I think really what's key here as we talk about our affordability efforts is that the exchange really represents only, about 4% of the individual market. So, or excuse me, of the healthcare market in Washington state. And so partnerships really are key when we're thinking about how to drive affordability for customers who are purchasing qualified health plans through the exchange. Let's go to the next slide. And, it's really important to think about affordability for exchange customers, because the primary barriers for our market for more of consumers in Washington state who purchase care coverage through the exchange, it's affordability. It's high premiums, it's high cost sharing. We have subsidies on the exchange, but deeper subsidization really is not a sustainable primary strategy for improving affordability. And we have to partner with you. We have to partner across the state to address underlying costs of care to really drive for affordability for Washingtonians and for those customers who purchase coverage through the exchange. On the next slide, you can see why. For the second year in a row, exchange premiums are going up by 9%. That has a big impact on being able to access health insurance coverage and health care as well through their benefits. And if you go to the next slide, you can really see the exchange customers not only are paying more and more for health insurance coverage, but they're paying more for health care as well. Exchange customers pay about 35% more when they go to the hospital than other commercially insured residents in Washington state. So as I said, if we go to the next slide, there's a lot that can be done, whether it's, through this board and its authority, through HCA, through the exchange, through OIC. Really, the point is that there are many things that states can do and should do, and we're all leaning in, whether it's the exchange or the board or healthcare authority or OIC, as Jane will talk about, or other, private entities or private purchasers. I think we're all leaning in to solve this affordability imperative. On the next slide is really just kind of a summary of what we're doing. And I hope what you see here is again, sort of that partnership and alignment. When we think about our role in price transparency, when we think about our role in quality measurement and sending similar signals to the market as other large public and private purchasers do. It's really important that we are playing that role as a partner so that we can effectively serve those who are receiving coverage through the individual market. We are a steward of the marketplace, and we really see it as our role to lean in with others and then also focus on efforts that are specifically focused on the individual market. And that's where Cascade Care comes in. And that's where I'm going to just dive in briefly here. So on the next slide, really, you can see kind of the high level of Cascade Care. This really is our primary affordability strategy in Washington state for the individual market. It recognizes that Washingtonians don't get the health coverage or care that they need because it's too expensive, as we've talked about. So the state's Cascade Care efforts really aim to make health coverage accessible and affordable for every Washington Health Plan Finder customer who's buying QHPs on the exchange. On the next slide, you can see some of the levers here. So with Cascade Care, we offer Cascade Care plans and Cascade Care savings. So Cascade Care plans really are the standardized plans that are designed for QHP customers and exclusively offered on Health Plan Finder. Those really are focused on making sure that folks can access both coverage, but also care when they use their benefits through lower deductibles, services before the deductible, and low copays. A subset of those standardized plans are the nation's first public option plan, which is administered and managed by the Healthcare Authority. We've talked about public option here at the board, and then also I'm going to be talking a bit more about that today. And then just to kind of round this out, we also do have a state subsidy called Cascade Care Savings that provides premium assistance to low-income customers who purchase those Cascade Care Silver or Gold plans on the exchange. So I'd really like to zero in, recognizing we only have a few minutes here on public option, so we can actually just go to the next slide. This should look really familiar. The Healthcare Cost Transparency Board developed and adopted and is submitting a report to the legislature about public option's impact on consumers. We're 3 years in, about to get into the 4th year of public option, and we're seeing a lot of promise when it comes to customer affordability, both in lower premiums. As you can see here, Cascade Care public option premiums are going up at a much lower rate than the rest of the market, so non-public option qualified health plans. But then also, as we talked about in the report that you adopted over the summer, public option plans through that standardized benefit design is also providing more access to healthcare with more affordable benefit design that allows folks to, go to the doctor and access high value care. And I think I'm just going to kind of end on this next slide and really talk about, where we are with public option and how it fits into your work and how it fits into the broader kind of affordability equation. So you saw that public option premiums are going up at lower rates. And that's really because public option is the lever that we have on the individual market, that we have through the exchange to drive affordability. And that's because public option plans are like all of the other QHPs, except they have higher quality and value requirements. And they're also required to meet state-defined provider reimbursement requirements. So these provider reimbursement requirements are really important because we know that a major driver of customer premiums is the cost of healthcare services and what carriers are paying providers like hospitals and otherwise. And so I just want to recognize that, and this board knows really well, that attempting to address the cost of healthcare services can make folks around the state a little bit nervous. And what I think is important here is that public option with these provider reimbursement caps is just a subset of the exchange. As I said, the exchange represents about 4% of Washington's market. Public option is 0.5% of the Washington healthcare market. So this really is a place like within public option, within this affordability mechanism, where we can innovate for better access and better affordability for customers and those customers specifically who are getting their coverage on the individual market. And if you jump to slide 14, you can see, or excuse me, not 14, but the next slide after this one. You can see we have a variety of reports, including the report that the Healthcare Cost Transparency Board adopted about public option and about Cascade Care overall, and how, 3 years in, we're seeing how public option and other components of Cascade Care that I talked about can be strengthened to ensure access and affordability on the individual market. So thanks for having me here today, and I'll pass this back to Michelle.
Okay.
Yes, it's correct, Jane.
Oh, but Margaret had a question.
Yeah, I was struck by the slide that said the exchange customers pay more for healthcare in terms of hospital costs. And I was surprised because I thought health plans would usually have one contract with a hospital for all their customers. So do they have separate contracts for exchange customers?
I think that's a good question. And I think it probably depends on the carrier. I think that what's important to recognize here is that the exchange, unlike other larger market players like PEB or SEB or other large employers in Washington state, we don't have, and nor do our customers have, the negotiating power to kind of think with carriers about how much healthcare is going to cost. So we might have, the exchange may be comprised of 220,000 people in a given year, but really that purchasing power and that negotiating power around healthcare costs isn't there for exchange customers. And I think that's what's really important when we think about that slide in particular.
Well, I do understand that in terms of the premium level, but I don't understand why the hospital costs would be so different unless they're just negotiating for this small slice of business separately.
Yeah. Well, I mean, again, when we know that when we think about employer-sponsored insurance, whether it's public or private, that there are these negotiations that happen between the purchaser, and you all know this, like that happen between the purchaser and the carrier, and then the carrier passes along those expectations, whether it be cost, quality, or otherwise, to the healthcare providers. And on the exchange, you know, there's not that negotiating power in the same way that's represented in kind of the data source here.
Laura Kate, could I add, as a preliminary indicator, Margaret, we see there's difference on the public option contracting. They are sometimes different networks, even in the public option contracts versus the rest of the health benefit exchange contracts. So they're not bringing their entire book of business along with the same contracts for the most part. It varies again, as Laura Kate said, by carrier and by product that they're bringing, but there really are some differences.
I think that's why you're seeing such a distinction when you zoom in on the exchange between public option and then those other non-public option plans, to Michelle's point.
Over to Jane. If there are no other questions. No, I don't see any.
Waiting for my slides to come up. Margaret, to your question, the carriers have to file their contracts with the Office of the Insurance Commissioner, and they're confidential, and we review the contracts to make sure they comply with state and federal law where needed. And I will say that we see variability among the carriers in terms of whether they have one contract with, for example, a hospital system, or whether they have multiple contracts for different books of business or different lines of business.
Thanks, Jane.
You're welcome. Okay, so thanks to everybody. I'm mindful of the time, so I'm going to be my best New York person and talk fast. So if we could go to the next slide. Probably the thing that's most relevant to the board's activities is a directive by the legislature in the 2023 budget to work with the Attorney General's office to undertake a healthcare affordability study. We've contracted with Health Management Associates to prepare the report, and the AG's office is going to be focusing their efforts with respect to the report on activities around healthcare mergers and acquisitions and anti-competitive contracting issues. Next slide, please. So in terms of what can be expected, on December 1, we'll be submitting a preliminary report to the legislature. And really, this report has two goals. Number one, we hear a lot of information about what's going on nationally with respect to the healthcare industry. And we wanted to be able to present to the legislature and others information about really what does the business of healthcare look like in Washington state. So that report is going to use whatever publicly available data there is to sort of say, okay, how much horizontal consolidation do we have? How vertically integrated? How many other services do health insurers own? Also looking at physician employment, how many are still independent, how many are employed by other entities, and then really trying to get a sense of private equity acquisitions in the healthcare industry in Washington state. So that's one piece of the report. The other piece of the report is really a broad overview of policy options to address affordability, including adoption in other states, as well as things like statutory authority and sort of where we are in Washington state. And really, this report is intended to say, here's where we are in terms of the business of healthcare. Here are some options that are available to affect affordability. And then in August of next year, we'll be submitting a final report. And the final report is going to do a very deep actuarial and economic analysis of a subsection of those policy options. So that's really, I think, the main deliverable from OIC that's specifically related to the Healthcare Cost Transparency Board's responsibilities. Next slide, but I want to just give you a little bit of a highlight, right? In Washington state, the role of the Office of the Insurance Commissioner is to approve individual and small group health plans. And when we do that, we look at not only the rates, but also whether there's an adequate provider network and whether the contract or the policy between the insurer and the consumer or the employer group has all of the information that's needed and is compliant with state and federal law. Next slide, please. And to make it really, really clear, OIC does not have prior approval authority for rates for large group health plans. Those rates are negotiated between the insurer and the employer. Where we do have prior approval is for individual and small group plans. And the really base factor in all of this is that when the insurers, and we can go to the next slide, when the insurers submit their rates to us, we have a whole team of actuaries. They have to show us that the rates that they want to charge consumers and small employers are actuarially sound. And so when we look at actuarial soundness, or like what goes into a premium, premium is essentially three things. It's medical costs. And in this case, it's an insurer's projection of what their medical costs are going to be in the upcoming year. Next slide, please. It's their administrative expenses. And remember, under the Affordable Care Act, there are caps on administrative costs. It's called medical loss ratio. And if health insurers end up coming in at a medical loss ratio that's below the required level, they're required to refund dollars back to consumers. And then the third one is profit or loss, or really, because so many of the insurers in Washington state are nonprofit, it's really how much can they contribute to their reserves. And that amount is usually 1% to 4% of the total premium that is charged to consumers. Next slide, please. So here's where it's been over the last 10 months. You can see that there's been a lot of change, a lot of variability in individual market rates. But I think one way to think about it is this: cumulatively between 2014 and 2024, the premiums for individual health insurance coverage have gone up by 112%. So a premium that was about $300 in 2014 is $625 next year. And that's the concern when we talk about affordability. Next slide, please. And I think Laura Kate shared what we've seen in terms of variability and what the rates look like. Next slide. But then the question becomes, okay, what's driving the 9% rate increase that we approved for individual market? Well, increases in price and utilization of healthcare services, including pent-up demand for elective surgeries that were put off during COVID, and definitely prescription drug costs, especially specialty drug costs that are physician administered. That's where we see most of the growth. The issues that Tom mentioned when he talked about inflationary pressures on hospitals, the carriers are facing the same kinds of inflationary pressures. So there's some administrative cost element. And then one of the biggest predictors is under the Affordable Care Act, when an insurer takes in their enrollees, one of the things that Congress wanted to ensure was that you didn't end up having one insurance company that had all the sick people and another that had all the healthy people. And so funds are literally transferred among health insurers to balance out, so that, for example, the health insurer that has a lot more sicker people gets money, and the one that has healthier people pays out money. And next slide, please. So that essentially is how we look at rates. And I just want to very, very quickly talk about ground ambulance balance billing, which is clearly a consumer affordability issue. Many of you may know that in 2019, we passed our own state balance billing law. In 2020, Congress passed their balance billing law, and the one service that was left out of balance billing protections was ground ambulance services. And so the legislature directed us to develop a report, which we submitted to them on October 1st. And very, very quickly, what we have learned is this is a complex system. There are 39 counties in Washington state, but there are 478 agencies that provide emergency services via ambulance or otherwise. Next slide. So And there's a big risk of balance billing for consumers, anywhere from $500 to $1,000 that consumers face in potential balance billing. But we also know that ground ambulance providers, I think I can say, provide a bunch of services or a number of services that aren't compensated at all. So the best example is when your local fire department sends an ambulance to respond and manages to manage somebody on the scene and doesn't have to transport them, that isn't a billable claim. They're not paid for that service. And the other thing that we know is that there is a really clear, not clear, but there's really dense involvement of both public, local fire departments, fire districts, and private ambulance services. Next slide, please. And so in the report, which will be before the legislature this session, we're already working with legislators on drafting legislation, will be a recommendation to prohibit balance billing of consumers for emergency and non-emergency transports, and to set a formula for payment of ground ambulance transports. And I will say, and you will understand this, that the biggest issue that's going to be before the legislature in that formula is where it sets what that fixed rate is going to be. That's going to be the biggest discussion. And the other recommendation really quickly that I wanted to point out is under our law in Washington State, if somebody needs services from a behavioral health emergency provider, like a mobile crisis response team or a crisis stabilization facility, that is treated just as if they had gone to an emergency room in a hospital. No prior authorization, no balance billing. And to align policy with that, this recommends that if a ground ambulance provider transports somebody to a crisis stabilization facility, they get paid just as if they had transported somebody to a hospital emergency department. And so given the time constraints, I am not going to go through the rest of my slides. You are happy to review them at your leisure, and happy to answer any questions.
Thank you, Jane. Are there questions from the board for any of our presenters? Bianca.
Thank you so much for this presentation. I mean, it's so rich with information. My head's swimming a little bit, but if I can just better understand, so there are requested rate increases, it looks like, compared to what's actually offered. And you mentioned that some of those rate increase requests are high for some entities because they're considering things like, say, high labor cost. And I just am noting that some of the smaller requested increases are coming from what seem to be more community-based groups versus larger increases seem to be coming from larger groups. And so I'm curious if you can provide any perspective on the inside knowledge around kind of what you're seeing about their different expectations about labor cost increase. Is it different across them? Labor is a huge part of what is driving those increases.
Yeah, I mean, I think that's a really interesting question. I mean, the insurers' labor costs are their costs for their employees. And the question, as we always know, is when you're looking at medical trend is a product of two things. It's utilization and price. And so when we look at the differences in the rate increases that have come up, some of it could be, I mean, for example, we've got coordinated care, which is a Medicaid MCO, and they're offering coverage in the individual market. And then you've got somebody like Premera that is a commercial health insurer that is, in addition to offering in the individual market, is in the small group market and the large group market. And so they're very, very different. And one wonders whether for those plans that are heavily in the Medicaid market and who tend to pay lower rates on the Medicaid side than commercial side, does that have an impact? there can be any number of things, Bianca, that influence what an individual carrier's rate increase might be. And then also it might be that in 1 year, their rate increase request is lower, but in the next year it's higher. And it's really variable. But what we do is we make sure that whatever they're requesting is justified. That's the most important thing.
Okay, thank you for that. Yeah, I realize it's such a complex relationship between what the insurers are doing and what they're expecting or what they're responding to versus what the different providers on the ground are expecting. So I can see that it's a complexity in that kind of contracting arrangement. So thank you for that additional.
Great, thank you. And I look forward to this ongoing work and the progress that you all will report back to us. So I know that's the last time we're going to hear from those three. Next, we're going to welcome back Vishal Chowdhury. He's our Chief Data Officer, and he's going to provide an update on the baseline benchmark and its analysis. Vishal, over to you. And this is tab 6.
Thank you. Good afternoon to the board. I'm going to try and share my screen. Please let me know when you guys can see my screen.
We got it.
Wonderful. Can you guys hear me okay?
Yes.
Thank you. Thank you for having me. I'm going to go through a quick slide deck, just sharing with the board where we're at. I'm going to start with a little bit of terminology discussion around what we are talking about. The different terms, we use so much information. The entire work of the board is based on data. So I think sometimes it's easier to just level set and talk about terminology, talk about the approach and where we're at. So just a refresher for the members, when the board started talking about the benchmark and we advised the board, and the board then set the benchmark numbers, the growth benchmark numbers, we were talking about total healthcare expenditure. That is the term on the extreme right. That is composed of two large buckets, the total medical expenditures and the net cost of private health insurance. The medical expenditures include everything that's, traditional claims, also the non-claims-based expenses, and also the out-of-pocket or the cost shares. So one thing that we can see in Jane's presentation is about the premiums, right? Well, the premiums may not go high if out-of-pocket costs keep going higher, right? We saw that with the high-cost plans. So this is intended to capture the entirety of the healthcare expenditure paradigm in order to measure that. So TME and THCE are two terms that you will hear about. I just wanted to kind of remind the board what those are. These are the different data sources that the team is using to calculate the total healthcare expenditures. You'll see the total medical expenditures bucket on the top. Much of it comes from the data call, the annual data call that Judy mentioned. But we also get like the non-claims-based, the non-traditional healthcare expenditure data from the HCA. We get data from the VA, from LNI, from the Department of Corrections. Similarly, for the net cost of private health insurance, it comes from the carrier data submissions, but it also comes from other supplemental data sources. And the team works on, collating all that information, putting it together, normalizing it, and then aggregating it to provide the information back to the board. I know we're running short of time. I'm going to go through these slides fast, but please feel free to stop me anytime if you have questions. So what's the analytic approach? The approach that the support team is taking is largely, we can largely put it in one of these three buckets. The left one, the gray one, is the determination of the benchmark itself. That is the first set of activities that the board undertook, and that will be revised on a periodic basis, depending on the board's decisions. The middle one is the part that I will talk about a little bit more later on. That is calculation of how is the health system performing against that benchmark. Again, macro level aggregate performance, right? And the third one on the right, in the bright orange, if you will, is the cost driver analysis. It's saying, okay, it's going up, down, or sideways. Well, what's driving it? And that gets into a lot more detail We're not going to cover all of that today, but I just want to set the stage. Just as a reminder, these are the benchmark targets that the board has decided upon. That was the gray bucket. That's the first set of activities that the board undertook. The second one, this is what we're going through now as part of the data call. The intent is to report on these broad 4 topic areas. Not all of them right now. We're going to touch on topics 1 and 2 for this year for the baseline analysis, and we're going to work our way towards addressing topics 3 and 4 in future years. But the key and the meaningful work that will underlay all this is the 5. It's the interactions between these 4 topics. So that's our analytic roadmap, if you will, at a very high level. Just from a system analysis perspective, understanding how is our health system performing overall against a target that the board set. The third one, the cost drivers, if you will, that's not a monolithic approach. And you'll hear from Dr. Dealman after this how IHME is approaching some of the work. But when we look at broad buckets of factors that are driving healthcare expenditure, you can put them under, there's a demographics. The population is getting older. That is going to drive sometimes utilization, sometimes just the clinical condition, and that links sometimes closely to the disease burden. But the disease burden can also be a factor of so many other things that is not just demographic. For example, what impacts does our changing climate have on the disease burden of the population overall? It's just an example of analysis that could be undertaken under that particular bucket. Pricing, again, those are market choices. How is the business of healthcare structured, and how does that relate to what factors might affect whether healthcare expenditure is going up, down, and sideways? And then utilization. Most of what we talk about is utilization. How much of something was used, right? But there are these other factors. And then there are structural factors. What do I mean by structural? And they kind of touch on everything. So they're in the middle here in this graphic. Structural factors would be, I'll take an example of behavioral health. The investment in behavioral health overall over the last 4 years is probably more than what it had been in the decade prior. Injecting that level of investment in that sphere, much needed, will have an impact on the healthcare expenditures in our space, right? So those are some of the structural factors that will play into our cost driver analysis as we move forward. Some of you might have seen this graphic before. These are the different analytic work streams that currently exist supporting the cost board. I'm not going to go through all of them. What I want to focus on today is the leftmost one is the cost growth benchmark itself. And related to that is the performance against the benchmark. That is the macro level health system performance analysis. That's what we're going to talk about. When Dr. Dealman presents, he's going to talk about how IHME is going to help shed a light on some of the other drivers of healthcare expenditure, and how they relate to one or more of the different buckets that I showed on the previous slide. If I'm going too fast, again, please stop me and ask questions. In terms of calculating the total, either medical expenditure or cost of private health insurance or healthcare expenditure, it's a very crude graphic depicting that we have 14 data submitters from the data call. In order to calculate the total healthcare expenditure, we cannot have an assumption that, oh, we got 12 out of the 14 submitters, we should be able to create reports. We can, of course, create reports, but it will be a subset of the total. It won't give us the total healthcare expenditure, right? So understanding that, and I'm bringing this point now, I'm going to visit it in one of the later slides. The data validation that the team does It does happen at a carrier level. Like when a submitter submits the data, we look at the data elements to make sure, okay, does it pass the smell test? These are criteria that it should meet. Is there a blank here? There shouldn't be a blank here, doesn't make sense. We ask the question. But then there's a validation that happens at the middle point where we're aggregating. Because sometimes when you aggregate things, the total doesn't make sense. Then you're going to go back and ask, okay, what did you guys give us? Right? So it's a layered approach to analysis and validation that will then result in an understanding of what the total medical expenditure and the total healthcare expense is going to look like in the state. So measuring performance against the benchmark. Again, these are the 4 levels. I kind of touched on that in one of the slides prior. The top 2, the state and the market level analysis, that aggregation, that is what the team is working on at this time. That is the baseline analysis. It's just to help the board understand, okay, we set a target of 3.2. What's the system performing at today, right? And what does it look like when we slice it a couple different ways? Getting into the provider and payer level details is going to happen next year onwards. We're going to start working on it next year. So where are we at? This is a fun chart that kind of helps me understand when we're looking at, on the right side are the different data submitters or carriers in the state, on the left side are the broad buckets, the market segments, if you will. You will note that there are maybe 3 straight lines in this that are not curved, and they are really, really thin. What that tells me is that if one of the carriers' data is not passing muster, if you will, it is affecting multiple market segments. So I can't say that, oh, only this carrier is missing, therefore the other part is going to be okay from a total aggregation perspective. The impact is actually cross-cutting. And we have to keep that in mind. Of course, we make assumptions, and sometimes we need to put some caveats as part of the aggregation. But then, you know, that's the approach. In terms of data submission, a lot of progress has been made in the last 12 days. The slide was created 12 days ago. We have 14 submitters. 7 of the submitters were able to submit it correctly and adequately the first time. And then you can see for other submitters, it took them more than a couple times to resubmit and correct the issues that were found. 12 days ago, we were still waiting on 2 submitters to submit the data. As of today, we have data from both of them. CVS has passed the validation checks. We still have some questions about the Anthem submission, and the team is meeting with Anthem tomorrow to go over those. And I want to thank Director Birch, because it was with her help that we were able to come this close to the finish line and almost over it with these submissions. We're also, when I mentioned the aggregate analysis and the questions that come up at that point, the team realized when looking at the analysis that there are some non-traditional claims, or not non-traditional expenditure information that we need. So we're working with the HCA finance team to explore that and get that added to the total analysis. Some limitations and caveats. Again, this is the baseline data analysis. We've had some submission issues. I'm not going to go through the list, but these are the things that the team encountered for the most part, sometimes multiple times with the same submitter, that we went back and talked to them. Yes, at this point, our analytic manager reminded me that for 14 data submitters, the team has validated the data more than 25 times. So, and just want to remind the board, our original time frame was we released the data call in August, September 2022. And we gave the data submitters 6 weeks, 8 weeks to submit the data. The original deadline was October 2022. So you can see that we've had a challenging time in getting the data submissions completed. It's taken us a long time. The original data validation and analytic timeframe was 3 to 4 months. Now the team has been validating along the way, so I think we can truncate that a little bit, and we're looking to a preliminary analysis by late November and a final draft by mid-December to submit to the board. I will stop there, and I'm happy to take questions. Or Sue or Michelle, if I missed anything, please feel free to add.
Thank you, Vishal, for that information. Board members, any questions? And I will just, I don't see any hands up. I will just say that we have heard from other states that the first year of this process is difficult. And I think it has been challenging, and our team has been working tirelessly since October of 22 to make this be timely. I think this is an area that hopefully our stakeholders in our legislature are going to help us improve in future years, because quite frankly, in some of these phone calls with the submitters who have not been punctual, there's not a lot of urgency on their part, and it has been a very frustrating process to not have any recourse or ability to sanction or fine them. Quite honestly, though, I get a little bit concerned because there's also sometimes an attitude of we'll get to it when we get to it. So I'm just curious, like, for the future, how this is going to improve. I know other states have had to be more aggressive with penalties. So we'll push to see what happens in this legislative period, but clearly it is important that we have accurate data, and that this process get shortened so that we aren't going through this administrative headache of all this cleansing the data and begging and working through the process. Edwin, you have your hand up.
Yeah, no question, really. Just a comment. Seems like it's been quite a labor-intensive process. I just wanted to thank Vishal and the team for all the hard work.
Yeah, on behalf of the entire board, Vishal, I'm going to echo Edwin's appreciation, because I know this has been very frustrating. So more to come. Any other questions for Vishal? Not seeing any. All right, we're going to transition then. We're going to move on to Joe Dielman. He is our partner at the Institute of Health Metrics and Evaluation. He's going to lead us through a discussion to enable the board to identify analytic products that will assist the board with the development of the healthcare cost mitigation strategies. Joe, over to you.
Thanks, Sue. Can everybody hear me okay?
Yes.
Awesome, great. Thanks so much. It's a privilege to be able to present. I'm excited to present today. The hope really is that today's presentation is more of a discussion than a presentation. And I know that's a little bit hard after an hour and a half of meeting, so maybe stretch. The good news is I think I'm the last major presentation. We're a little bit behind, so I'm going to move quickly, but I do want to emphasize that we really want to hear from you on how to make the support that the Analytics Support Initiative is trying to provide as useful and beneficial for the board. So with that, I will remind you that, that this is kind of our course. We're in the first phase of this project. The first 6 months of the project is really just focused on determining what we're going to do. And that's where we're at. We're probably about halfway through that 6-month period. Then we take a year to do the analysis that we've talked about. And then finally, the last 6 months of the public-private partnership is essentially using the analysis that we've done. And so today I'm really just going to focus on this first part. We're still figuring out what we're going to do and really want feedback from you. And so appropriately, today's goal is just to essentially look at a menu of potential analytic products that our group could offer and look for feedback from you. And then I'll come back in December based on the feedback gotten today with a much more fleshed out plan. And so just to be super clear, I'm going to present to you 8 potential ideas. They're not exclusive in the sense that if there's something different that this group wants to see, you can propose it now. But I would like to walk away at the end of this hour with some feedback on which of those 8 stand out. And I think we have the bandwidth to do 2, maybe 3 of those, maybe 4 of those over the course of the next year. One thing that our team did when thinking about what the criteria should be to pick out those strategies was just brainstorm what would be best for the board. And so these are our ideas. They haven't necessarily been passed by you guys, but I think they are important criteria that you might want to use when evaluating these potential projects. And so one of them is we want, of course, support a clear identified need of the board. It's imperative that what we give you at the end is simple and clear and understandable. We want it to be granular enough and specific enough to be able to act on. We want it to have a high probability of being influential, so able to do something. And we want that high probability, the influence to be meaningful. And finally, Vishal just presented, there's a number of major analytic initiatives going on to support the board. We're just one of them. And so we want what we're going to do is to not be duplicative. We want it to be novel. And so those are some suggestions for how you might want to evaluate the potential projects that I'm going to describe here. So now I'm just going to walk through those 8. And then I think after that, kind of mostly open it up for discussion to talk about these potential 8 ideas. And again, I want to make it really clear that you're not limited to these 8 ideas, and we can take hybrids or merge or think about new things. But this, as our team has brainstormed with the HCA, are kind of the 8 things that have stood out. So the first is really just thinking about reporting spending levels and trends. Our research project is set up to do that by health condition, by county, by payer, and by type of care. And so that kind of simple reporting of highlighting where there's the largest growth rates, be it county or cause or type of care, is something that we can provide. One thing that we can also do is consider risk adjustment. I think there's a lot of concerns about risk adjustment, appropriately so, because of the way that it's often done by connecting to claims data and upcoding. The way that we would do it is different than that, and I think would get around some of those issues. And it would really focus on the risks of the population and the disease prevalence of the population that is present in the counties that we're exploring. And so if we do decide to really focus on simple descriptive reporting of where growth rates are the fastest and where levels are the highest, then we can make a decision if we want to prioritize just the simple reporting or if we want to do some sort of risk adjustment. We have our own drivers analysis that would be a little bit different than what Vishal was just presenting on. It prioritizes kind of breaking the drivers into slightly different pieces. One of the differences is that ours at least aspires to include managed care as well as long-term care, which I think the current approach is not able to, the current drivers analysis is not diving into. And really what makes our analysis valuable is the connection to disease prevalence. And so our health condition categories, of which there's about 160, are all aligned with disease prevalence. And so we can look at changes over time, and we can break out which of those changes is due to underlying changes in the disease prevalence. People become obese, diabetes goes up, but that's not so much maybe the health system factor that we want to be focusing on. So that ability to control for or back out the impact of disease epidemiology as well as demographics is something that we would really focus on. Another idea is to really focus on comparisons. I think this is the idea here is to identify like counties. And so we would look nationally for counties like each one of the Washington counties where we are matching on some known characteristics of the county. Maybe they're wealthy, maybe they have an older population, Maybe they have a high homeless population, those sort of factors. And then look at the growth rates, again, kind of described in A and B, but after, with more of a relative comparison. E, the third one the fifth one is to look at a measurement of value. And this is something our team has done before, where we look at health system, delivery system value for the entire delivery system as a whole. The way that we would look at this is county by county. And so we would look at which counties within the state have high value. We could compare against some out-of-state counties as well. And get a measure for value, where value is really the intersection of spending and health outcomes. So that's an option as well. There's a lot of interest nationally at looking at the impact of hospital market concentration and prices. We could do an analysis that is Washington specific, so focus just on Washington hospitals and consolidations over time, and identify and report back on the impact that we see that has had on prices. Letter G, we could focus just on where there is variation. So our data that we're using for this project is not allow us to identify individual providers or payers, but it does allow us to say, hey, this is where we're seeing price variation. This is where we're seeing utilization variation. And so highlighting those spots is that kind of potential analytic product. And then the last one is relating to spending effectiveness. This is looking by cause at where we're seeing the most healthcare spending in the state. And so this would identify causes like diabetes or low back and neck pain, where we're spending a huge amount of money, and ask the question of how effective is the spending at reducing health burden. So those are kind of the 8 ideas. And again, we're going to have a discussion in a moment on kind of what those, what might be best of those 8. Again, here is the kind of 7 requirements that I think we want to have. And then the question is, how do we map those together? And so in this slide, what I have on the left is the 8 potential analytic products. Again, we can mix and match and merge. We can think about hybrids as the board would find most useful. And on the right is the list of 7 things that we think are, common sense criteria for a project like this. The last thing that we've done in trying to kind of prepare for today's conversation, actually the second to last thing we've done in trying to prepare for today's conversation, is just ask ourselves which of these 8 different projects has specific strengths and what the specific challenges might be. And so here you kind of see that we've identified some of them as being simple, meeting that standard, and others of being quite complex. And so if you look at assessing delivery system value for letter E, you'll notice that we found that one, after kind of careful consideration, to not be tremendously actionable. Identifying the counties of higher value versus lower value isn't give you a clear lever. And it's a very complex analysis. And so while we're putting together this menu of kind of opportunities, we also want to be super candid of where we see there to be strengths and where we see there to be concerns. And so really the ones that stand out, and this will be a little bit of a theme, are the top 4. Those are the ones that I've talked about first, and there's a reason for that. They really stand out as being simple, as being straightforward, and potentially invoking actionable insights. The other thing we want to do is think about how this meets an identifiable objective of the board. And so this really poses the question, what do you think you're going to be doing in the next year? And if you could, have a crystal ball and see your future, the board's future, what might be useful? And so our last activity was to look at common activities of cost boards. And so this is a list from Commonwealth that they put together of state action in 2022 related specifically to cost boards. And, we kind of wanted to take this list that they thought were, potentially actionable opportunities for the cost board in general, and try to map it against our 8. And so, you can see on the left that they're talking about things like addressing facility fees, capping provider rates, strengthening insurance review, looking at consolidation, looking at anti-competitive contracts, limiting out-of-network charges, looking at prescription drugs specifically, looking at population-based provider payments. And so what we did, again, as our last kind of exercise to try to identify which of these 8 categories really stand out, is we mapped them to each of these kind of generic potential opportunities that the, that the cost board might be excited about pursuing. And again, it's kind of A through D that we saw, and G that really stood out as applying to this list. And so if we go back, and this is kind of the final slides, is, this, based on the last slides, we kind of identified that E, F, and H don't stand out in our opinion as the maybe the lowest hanging fruit. You'll see that those items are considered complex or not actionable, and really kind of focused on thinking about risk adjustment and drivers analysis and comparisons with other counties. And so the 1 and 2 here would be potentially the way that we approach the analysis, is that we start by building out comparisons that are risk adjusted with like counties, and then we transition potentially to the drivers analysis. That's just what our internal analytics support group initiative has kind of focused in on. What we really want now, and that's really the last slide, is to ask the group in that very brief, quick introduction to these 8 projects, if there's some that you see in particular stand out, or if you have questions about any of the 8. And so I think we have about 12 minutes remaining, 13 minutes remaining, and really just going to leave it on this slide with the idea of trying to answer the questions that you see on the right side of the slide. Is, should we in fact focus on B, C, and D? Those were what our group was kind of leaning towards. Are there just things that are obviously missing, strategic opportunities that the board knows it has, that these analyses don't support? And then, finally, does this meet the key requirements? Are there, is it simple? Is it clear? Can it be communicated in a concise way? Does it fill a gap or a need of the board? So with that, I'll kind of turn it over to the board. Again, I'm happy to answer questions about these 8 products, but I'm also especially to hear your perspective on which of these 8 products might align with some of the, projects that you envision for the future of the board.
Great, thank you, Joe. Very well done, and I love how you visually laid it out with the overlay and the tie to Commonwealth. So thank you. I think it takes a very dense topic and kind of breaks it down. Margaret, I see your hand is up. Go ahead.
Yeah, this is an excellent presentation, and I agree with the recommendations. In terms of various policies, I'm intrigued by the one that is promote adoption of population-based provider payment and explore global budgeting. So I think it would be great if the analysis could be oriented to that possibility as well.
Great, thank you. Lois?
Yeah, I was just going to comment, the 2 that stuck out the most to me were the driver's analysis, C, and then G, variation across providers and payers. And those, the driver's analysis seems most like that's where we could have an eventual impact and help reduce costs.
Right.
Jane?
A question, Joe, about what you would consider a like county, only because, right, we've got significantly fewer hospital beds per 1,000 than other states, right? We tend to be, Washington State for decades, right, has tended to be sort of a more efficient state when you look at Medicare, geographic adjusters for Medicare, RBRBS, et cetera. So I'm just trying to figure out what the value would be of looking at like counties and how we would define them.
Yeah. So I think as far as the value proposition goes, that's in some ways, that's my question for you guys. I can hypothesize on that, but I'm really keen to hear from the group. As far as what we would match on, to some degree, the sky's the limit. Anything that's can be measured by county through, any one of the major surveys, be it through CMS or through Census Bureau, we could match on. I think we'd want to be really careful in thinking about those factors, right? We want to have factors that we think describe the environment, but we don't necessarily, we don't want the impact of those included, right? So anything you match on is essentially kind of removed from the analysis. And so if you are looking specifically, let's just use a silly example. If you want to know something about prices across 2 different counties, then you can't match on prices, right? That kind of goes without saying. You can match on anything that you are not directly exploring. And so, I mean, I do think we would put a lot of thought into asking the question of, what's our universe of things that we could match on, and what would we choose? And I think at this point, we don't have that list. But we would, of course, take feedback from both the advisory groups as well as the board itself. Do you, Jane, if I could ask, do you have priors off the top of your head that this is what you would want to match on, or you would absolutely not want to match on?
I'm not smart enough to answer that question. All I know is I'm not positive about the value of comparing us to other states or other counties.
Okay, great. Thank you. That's really helpful.
And Joe, before we move on, I concur with Jane, having done a lot of national work and traveled. I think it would be fascinating, but I'm not sure it is going to allow us then to implement or to have kind of next steps. I think initially, I think there's such strength in these other products. And I think the alignment between your team and our team is what is so critically important, to get all these smart people working together from different perspectives. So I just would concur with Jane that I'd be a little bit, I think it might be a wonderful junket if we had nothing else to do, but we have so much more immediate stuff that we got to get to the basics. But let's hear from more of our board members. I think it was Edwin, then Bianca, and then back to Margaret. Is that right? Oh, and Kim. Oh, go ahead.
Thanks. Yeah, I kind of came to the same list, kind of working similarly in a backwards way from by elimination as well. Might challenge you here a little bit, and maybe some potential amendments here. I think like the driver analysis, I think has always been a high priority for the board. I think that's a definite. I think back to the question about the option D. I wonder if you could reframe that in a way that it looks similar to option G, or maybe embed those together and maybe take it from the frame of instead of comparing like counties, because I think I agree with some of the issues that Jane raised, but also kind of methodologically, I find that pretty challenging, and that it's kind of sounds like with the propensity score matching, where you can match on the observables, but there's a lot of unobservables, right? So what looks like a like county may not be. So I think that's methodologically challenging and might be difficult to jump the line across. But I wonder if you could change the frame in terms of kind of quality performance reporting, which it seems like what you're trying to do with option G, where you do risk adjustment and other adjustment to get sort of adjusted variation across providers, payers, and counties. I think that might be a potential idea. Also, I wanted to maybe challenge you a little bit on B, because as you mentioned, risk adjustment can be challenging, and there's a lot of ways to do it, limitations to these different approaches, particularly because we have such a heterogeneous population here in Washington State. I was wondering if you had any sort of preliminary thoughts of how you would approach that option B.
Thanks, Edwin, for those comments. I think, risk adjustment, and if cost boards should risk adjust, has been debated quite a bit. I think there's a general consensus from providers and payers that we are all unique and there is a need to risk adjust. And I can, that makes lots of sense to me. Each facility or payer feels different. And then I can also understand, I think in general cost boards, or at least some cost boards have come down and said, you know, there's too much complexity and there is also this kind of major well-documented concern about upcoding that means that risk adjustment isn't doing what we wanted to do. What we would envision is not using claims data. Remember, what we're reporting out on is at the county level. And so we would be adjusting counties. So we would be saying, here's obesity rates in King County and Pierce County, and we want to set them equal for this comparison. And we would do that in the same way that you would do normal age standardizing, right? We know that you don't want to compare Utah and Florida if you're doing state comparisons, because Utah is really young, Florida is quite old. And so we adjust for that. In this case, we would be adjusting for things like risk factors, smoking rates, obesity rates, as well as age and sex. So that's kind of what we mean when we say risk adjustment, and staying far away from the claims data that I think has led to a lot of controversy about if it can be done well.
Maybe if I could just sneak in a quick follow-up there. I think,
yeah, of course.
Do you have a validated, because you're doing this at the prospectively at the county level, and I know internally at HME you have a lot of different metrics. I mean, do you have sort of a good validated, ideally in literature, kind of measure of risk adjustment that you would prospectively be using in option B?
Not that we've published on.
Okay.
Yeah, we have done this on multiple occasions, and that's why, you know, kind of the approach is relatively clear to me. But I'm trying to think of a place that we've published on it, and nothing's jumping out to me.
Okay, no thanks. I'll go and pass the baton.
Yeah.
I think, Kim, were you next?
Yes, but actually, part of it was just covered. I'll just shorten my comments to say that I do support B, C, and G. I think especially well, all three of those. And I really am especially interested in as careful and sort of astute exploration or picture that can be determined regarding the spend related to what we're buying, i.e. health. So I think the more that we can see potential relationships, expected and unexpected relationships between levels of health and levels of spend and the types of spend, you know, sliced by different, whether geographic regions or by different subpopulations, that, you know, is really, really interesting. And then it helps with policy making, that you don't just throw a sort of wide policy solution that actually needs to be more discrete or targeted. So I think understanding, you know, the starting, you know, broad, macro, all of that, maybe necessarily, but I'm just really intrigued by the possibility of understanding more discrete subgroupings where we're spending a whole bunch and not getting much. You know, that kind of mismatch. Thank you.
Kim, thank you for that. We are coming to our time. I'm sure Joe would welcome any direct comments or further deep dives into this topic. Ingrid did want me to represent that she has a lot of keen interest in B and C and possibly G. I really hope that, Joe, you'll continue to work with the data leadership. I know you will at Healthcare Authority, so that you all can really kind of match up this work and come back to the board. But you've heard kind of the board's comments thus far. I know this topic's coming back. Board members, so thank you, Joe. I want to thank everybody for attending today. I want to remind the public and the board that the recording and the summary of this meeting is going to be posted shortly on our website. Presenters, thank you. Always such rich information. Public commenters, thank you. Again, we're ingesting all this data as we move slowly forward through the future. Our next meeting is going to be December 7th at 2 p.m. And I look forward to seeing you at that next meeting. This meeting is adjourned. Thanks all.